Thank you. To Dr. Kim, for the bicep split technique here. Thank you, doctor, for your sharing your knowledge. What is the effect of rerouting of the bicep on the articulation? Does the bicep pull down the humeral head, or what is the effect to protect the supraspinous plastic?
Very nice question. Before doing that, I am very worried about just leaving the biceps pathology at the group. The American used to like to do the subpectineal tenodesis because there is they thought there is a pathology at the group, and if you just leaving that, you can make a post-operative anterior shoulder pain. However, when I did the animal study, if the biceps cut, when you know that if there's the flexor tendon tear, it adheres to everywhere. So after the biceps cut, I think it's a groove at the groove. There is an adhesion, like we call it autotenodesis effect, right? Mm-hmm. But the proximal part, it's not moving anymore. You know, it's fixated to the articular margin. So hopefully, we hope that the pathologic biceps adhere to the rotator cuff as well, but it's not going to happen as you desired. But in some post-op MRI, you cannot just define both two. I think it's sometimes they merge together. However, I think it's not goes permanently. Sometimes it's torn because it's a pathology. So it's just like I said, it's a splint. You know, every rotator cuff tear, not every, but the majority of rotator cuff tear occurs in the early period. So at that time, I think it could work as just a splint to protect, the fracture or something like that.
Okay, and there is any landmark to put the anchor, like posterior to what structure or something?
Yeah. I skipped it a little faster, but you can choose the location. If you think that the anterior part is the weak point, you can move a little bit anterior, like L shape. Yeah. If there's a split between supraspinatus and infraspinatus, like a posterior part is weak, you think it's weak, then you can move a little posterior. But okay. If you go posterior, then you can make a more kiloton. So that's a little problematic, but I think it's okay.
Okay. Mm-hmm. And the last question, if there is any lipstick sign or sign of tenosynovitis in the bicep, does this technique can be done without tenotomy?
Yeah. I think so, because as I told you at the first question, even the biceps synovitis at the groove, if it's not moving anymore, then it sticks together.
Okay. Thank you.
Other questions? There is one in the back.
Hi, I have one question for you too, doctor. When you do the muscle advancement, how much can you advance of the supraspinatus? How much length?
Actually, all the origin of the supraspinatus is gone. If you do well, then it's a free muscle. Only the nerve is attached to the muscle, so you can bring it to whatever you want, but you cannot do it. So it's about the 5 centimeter. Well, when think of the retraction, Patek grade 3 retraction, then it's a 4 to 5 centimeter, right? So you can reduce that much. So I think it's a pretty much whatever you want. So you can make it irreparable to repairable. However, there's always concern with the suprascapular nerve damage. Okay.
And one other question. If you do that, what is your age gap, your age limit for doing that advancement?
Yeah. But because if the joint is narrowed and a patient is sedentary and over 65, it's a very the cumbersome procedure, and rehab is a little bit longer maybe. So the reverse total shoulder is a fine procedure after the 65 or 70. So yeah, I would say the muscle quality is good still. If patient is active, he or she has to do some of work for living. Then and joints should be preserved. Like you cannot do it in CTA condition. Okay.
Okay, and for Dr. Mustafa, we have done it all with irreparable rotator cuff tears, but I saw in your presentation really aged women with probably more than 70-year-old with pseudoparalysis, and for us in our hands, when they have pseudoparalysis, it's really, really hard to move it again. So I saw what you did, and with the results are really, 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 really good. Honestly, when I saw that patient with pseudoparalysis, more than 70-year-old, I thought maybe a reverse total shoulder arthroplasty is the best option. But when I see that, the results are really, really good. How did you decide to do this surgery instead of reverse shoulder arthroplasty? But because even if you don't have joint degeneration, with the pseudoparalysis, it's really hard to move again.
Firstly, we have to check the degeneration. If there is no degeneration, firstly, we don't take arthroplasties. We check, especially patients' superior migration. If there's a fixed superior, anterior superior humeral migration, you can take arthroplasties, but there is no static superior migration. If there is no joint degeneration, we must check the subscap. If subscap repairable, first thing the transfers. If you have intact subscap or repairable subscap, you can do latissimus dorsi tendon transfer, but subscaps is minimally degenerate or repairable, but medial is repairable. The fourth couple will not be created with the latissimus dorsi, so you can choose lower trapezius.
Okay.
You can use lower trapezius not only for the abduction, for the external rotation. We first described approximately 90.09 for only external rotation.
Yes, because sometimes we have patients more than 65-year-old, and they are active, and sometimes I prefer to do a partial repair and probably put an subacromial balloon on. I don't know, doing the most but the less as possible for them to improve their movement and the pain, no? But sometimes these kind of patients are really, really difficult with pseudoparalysis. They are really, really, for us in our hands in Mexico.
Yes.
So maybe if I can also comment on your question, that's a good question. Of course, if you have an older patient with pseudoparalysis, in my hands, I go for a reverse and don't do any muscle transfers. I don't know how high your success rate is, how many latissimus dorsi patients from coming that doing this. I don't know, you can tell us, but however, in my hands, 65, over 65 doesn't get any muscle transfer. So under 65, although they have pseudo paralysis, I always think if I should go for a muscle transfer or go for a reverse. So that's a difficult topic for sure. So yeah.
In last dorsal transfer, we have not only tenodesis effect, we have active massive effect. If the transfers to the latissimus dorsi up to the biceptal groove, so we can create glenohumeral depression. So in this depression, if we create subscap repair and infraspinatus repair, we create a force couple. So with the active latissimus dorsi transfer, we can improve the movement.
I got one question for the Dr. Say. Speaking about the sprinting technique, in your revisions about shoulder rotator cuffs, is that a problem, or what did you do with that splinting, you know, in your revisions surgeries? Is that a problem, or what do you use it again? What's the technique?
You mean bicep splinting in revision condition? Actually, I haven't. Is there someone that have so many? When you do it after you saw the retear, you tend to not, you know, the touch it again. I think that the surgeons have the same mind. If you have you see the retear done by others, patient have pain, then you force him to do the revision surgery. But yeah, it's just a joke. But yeah. In the bicep splinting, when there is a rotator cuff is torn, usually torn 100%. So you cannot use it again because there is no bicep tendon left at the proximal origin whatsoever. So in revision situation, in that case, you cannot use biceps again. So you have to choose, like you have to do the if the patient haven't had gone advancement and the patient had a good muscle quality, then you can do the muscle advancement again. However, the patient had the very poor muscle quality, then you can choose to do the LTT or whatsoever. And if patient age is very high, then you can do the reverse. Okay. But even though in revision situation, the muscle advancement works well, okay? Because if the muscle if haven't touched before, it works good.
Thank you. Can I ask you a question? Did I understand you right? You do the splinting in every case where you repair the cuff?
No.
Why not?
When you know in the WashU study, biceps the rotator cuff tear start from the posterior to the bicep tendon like the 5 to 8 millimeter. So when even though supraspinatus is torn, you see the posterior the pulley is intact and some tissue is intact there. So when you do the bicep splinting, you have to sacrifice those tissue and you have to remove the pulley, posterior pulley. So in that case, biceps is usually normal. So just a rotator cuff repair is possible, and I think it's sufficient. And the condition that I do the bicep splinting is like two: posterior pulley lesion and the bicep partial tear. That's two main condition I do the bicep splinting.
Okay.
Okay.
And do you have any concerns that the biceps is not healing to the cuff, which you repair?
Yeah. Like I told you, I think there's the synovium, it covers to the biceps, so it's not always, as you hope, that sticks to the rotator cuff, as you hope, but I think it's not happening to every case. But some case, I think it's possible.
Any other questions? Then we would thank all the presentators and go for a break. So we're gonna meet like planned at 11, right? 11 o'clock? Here again? Or maybe 5 past 11? So see you here in 5 past 11. Thank you.
Before the break, I would like to invite everyone to the stage for a photo.